Let's talk a little bit about magnesium. Magnesium is interesting in that this is the only electrolyte that become a little bit more bullish on repleting. I think partially because it's something where hypomagnesemia has very clear risks and potentially serious morbidity mortality associated with it. And also because, as we see in a lot of pregnant patients, people tolerate pretty impressively high levels of magnesium at times with really minimal to no ill effects.
As you said, Ben, I think the data is best for magnesium amongst the three electrolytes that we're talking about. There were randomized control trials of giving magnesium to patients with acute MI that showed benefit. This wasn't borne out in the most recent rigorous trials, but there's at least something that said if we give magnesium to a patient with acute MI, outcomes are better. Atrial fibrillation, I love giving it for patients with atrial fibrillation, though again, the data is plus or minus on that. And there are many other conditions, asthma is another one you mentioned, where magnesium is beneficial. I mean, I don't use it for preeclampsia because I work at a veterans hospital, but I've heard it works there too. And if we go back to potassium for a second, if you have hypomagnesemia, your ability to retain potassium by the kidney is mitigated. And there is data that if you have a patient, if you just give them magnesium and no potassium, the hypokalemia will get better. So if I have someone who's got a potassium of 3.2 and a magnesium of 1.4, my advice is just give them magnesium. The magnesium will get better. And you know what? The potassium will probably get better too. I don't remember ever writing problem number 2, hypermagnesemia. It happens, but we're talking patients who have severe renal dysfunction who can't excrete any magnesium. And so being a little bit more bullish, to use your word, and I think is reasonable because harm is probably less. And then there is some data.
What are your thoughts on IV versus PO, magnesium repletion?
Right. So the PO can cause diarrhea, as far as I understand, an osmotic diuretic. And that's unpleasant. I mean, it does work, but not all the elemental magnesium that you're administering to them is going to get into the body because, again, it's causing diarrhea. But here's the thing with IV that I think the listeners need to remember. If I give someone 2 grams of magnesium over a short period of time, let's say less than 1 or 2 hours, the serum level is going to rise. And then the kidneys are going to be absolutely awesome at excreting that magnesium. And so you might excrete 20, 30, 40, even 50% of what you've given to them through the IV is just going to go out in the urine. So the preferred way to do this with lower levels of hypomagnesemia is to give it over far longer periods of time. What you want to do is you want to slowly raise it and give it time to get into the cells and not jump it up to a high value, excrete it all, and then you're back to square one. Now, the biggest problem with this, of course, is no patient really wants to be hooked up to an IV magnesium pump for 8 or 12 hours. But if you've got a patient who you really think is severely hypomagnesemic and you need to get their stores up, you have to give it over longer periods of time or else the patient's just going to excrete a lot of what you give them. Just be mindful of the fact that the biggest drawback for the IV formulation is you're not going to keep most of it. You're just going to pee it out.
Yeah.
For my garden variety patient, I prefer magnesium oxide oral. And you know why? Because most of my patients are constipated. But if I have someone who already has diarrhea, sure, if I can give them magnesium oxide, but what percentage of my patients are already on polyethylene glycol and senna? It's over 80%.
I'm curious, is there a number of mag that you get nervous about?
So certainly less than 1, even less than 1.5. But I'm more bullish on magnesium, meaning let's give if it's less than 2, not necessarily N rounds to go put in that order. But this, going back to 4 and 2, the numbers we think about for potassium and magnesium, I'm okay with the 2. The 4 is a bit aggressive.
If you do have somebody who comes in with hypomagnesemia, how are you thinking about them?
Yeah, basically, I'm okay, are they on a PPI or are they on a diuretic? I have seen many, many cases at this point of a PPI-induced hypomagnesemia. It's not uncommon that I'm telling teams to check a urinary magnesium on a patient who's hypomagnesemic on a PPI. Because if their urine magnesium is low, that suggests that the kidneys are not the source of magnesium wasting, but rather the stool. And then let's think either transition them off the PPI if the indication is no longer there, or putting them on an H2 blocker. I think H2 blockers maybe have a similar effect, but I don't think it's as strong. There's a New England Journal of Medicine case report that shows these curves just up and down, like PPI stop, magnesium goes up, PPI reinstituted, it plummets again.